And you would think that diabetes is a much more tough area to manage, and so is hypertension in comparison to gout. Second, during acute flares, serum uric acid is often normal. Why? Because the inflammatory cytokines like IL-6 have a uricose-uric effect and lower the level of serum uric acid during the acute attack by about 2 milligrams per second. Premenopausal females are protected by estrogens, and estrogens do not allow hyperuricemia because estrogens themselves are uricose-uric agents. So this is important. A young female to diagnose as gout is not to be done. Urate lowering therapy means treatment that inhibits the enzyme xanthine oxidase and therefore reduces the production of uric acid. This is the commonest form, reduction of formation of uric acid.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
These 10 questions all have yes as the answer. And some of the questions might surprise you. You may not think that the answer would be yes, but all of them have yes as the answer. And after each question, we'll have a slight discussion, little discussion on that subject within gout. So let's come to the first question. As I said, every question has yes as its answer. Are physician errors more in the management of gout than in the management of diabetes or hypertension? And you would think that diabetes is a much more tough area to manage, and so is hypertension in comparison to gout. But I must tell you that the maximum mistakes in management of these three diseases are made in gout. As Dr. Kumar said to me that, show me a good management of gout and I'll show you a good physician. So why is this so? This is so because the management of acute gout with pain medicines is as erroneous today as is the management of prevention of recurrent gout. The errors are more of commission than of omission, and I will come to these errors in the next 9 questions. This is the second question. Can acute monoarticular arthritis be due to gout if serum uric acid is normal? As you know, gout more commonly presents for the first time as a monoarticular arthritis, typically as the acute arthritis of the metatarsophalangeal joint, first metatarsophalangeal joint. The affliction is called podagra, as you might know, and this podagra is the commonest manifestation. Maybe 50% of people will present with this, and 90% will ultimately develop gout of the first metatarsophalangeal joint. But what often happens is a patient comes with a monoarticular inflammation, and you do a uric acid which is normal. You tend to think that this then is not gout, and you look for differential diagnosis, which can be palindromic rheumatism, which can be tuberculous arthritis, which can be traumatic arthropathy. So, but you must remember that the relationship of uric acid levels to acute gout is skewed because the inflammation substances like IL-6, they reduce the serum uric acid because they are uricose-uric agents. So here is the relationship between hyperuricemia and gout. First, and this is very important, chronic hyperuricemia is a prerequisite for clinical gout. It is said that high uric acid levels are usually present for 5 to 10 years at least before clinical gout appears. You cannot have clinical gout in the absence of chronic hyperuricemia. The total uric acid load in the body has to be high. There are sometimes microtophi within joints caused by this chronic hyperuricemia, which will erupt in favorable circumstances. So that is one. Second, during acute flares, serum uric acid is often normal. Why? Because the inflammatory cytokines like IL-6 have a uricosuric effect and lower the level of serum uric acid during the acute attack by about 2 milligrams per cent. So a normal level of uric acid during acute attack should not rule out gout. In fact, about 25% of patients will have a normal uric acid level. Third, one must check serum uric acid level after a flare. Remember, after a flare, when the inflammatory cytokines have normalized, the uric acid will go back up, and then it will almost always be about 6.8 or more. So this is important for the diagnosis of gout in retrospect. And another important thing is, not all patients of chronic hyperuricemia will develop gout. In fact, a small percentage, even if they have high uric acid, a small percent only will develop gout. So this is the relationship between uric acid levels and gout. Let's go to the third question. Is it correct to consider gout as an important differential in young females presenting with monoarticular arthritis? Say a young female presents with acute ankle inflammation, swelling, severe pain. This young female is not menopausal. She's premenopausal young female, and she's not having any chemotherapeutic drugs. She's not on hydrochlorothiazide or other diuretics. Such a female, if she presents with acute monoarticular arthritis, she will not be having gout. Estrogens. Premenopausal females are protected by estrogens, and estrogens do not allow hyperuricemia because estrogens themselves are uricosuric agents. So this is important. A young female to diagnose as gout is not to be done. Here is the relevance of age and gender in gout. Gout is, of course, more in males than in females. Within females, after menopause, the incidence becomes equal. Gout starts in middle age because, as I told you, it takes 5 to 10 years of hyperuricemia before clinical gout appears. And estrogen, of course, protects. Women represent only 5 to 20% of all patients. Women with gout, and this is an important statement, women with gout are almost always postmenopausal and are often hypertensive on diuretics. As you know, both thiazide diuretics and loop diuretics cause hyperuricemia, and any patient, male or female, on diuretics will have some elevation of uric acid. So women, especially who are postmenopausal, because they are postmenopausal, often are hypertensive, they are often on diuretics, and this can cause gout. An important factor related to age. You do remember that gout starts as a monoarticular usually, and sometimes then progresses to oligoarticular or polyarticular arthritis. It then, instead of acute episodes, it can become a chronic arthritis. Chronic arthritis takes several years to set in, and therefore chronic arthritis due to gout typically occurs in the elderly. You must remember this, and this is very important in the natural history of gout. The first episode will occur, say, in the 30s or 40s. Between the first and the second episode, often there will be months, often years before the second episode comes. Between the second and the third episode, the gap might shorten, and then gradually the gap keeps shortening, and patient, if untreated, keeps getting more frequent episodes as years go by. So the graph is spaced out in the beginning and narrow in the later stages. Hence, when recurrent episodes occur, then the deposition of tophi in the joints or in the periarticular area makes the gout destructive and causes chronic arthritis. The last point, middle-aged patients have predominantly lower limb disease. Involvement extends to fingers, wrists and elbows, more commonly in the elderly. The distribution of joints is typically typically lower limb joints to begin with, lower limb distal joints to begin with, metatarsophalangeal joints, the ankle joints, the tarsal joints, then maybe the knees. And when the upper limb gets affected, it's usually many years have already passed. Shoulder joints rarely get affected by gout. The next question, can we be less strict on diet? Remember, all the questions have yes as the answer. Can we be less strict on diet restrictions in persons with hyperuricemia and gout? I'm often surprised by the list of don't take these foods given to patients of gout by doctors. Even vegetarians are subjected to harassment, I think. They are told not to eat sprouts and pulses and dals, green leafy vegetables even. I think we must unlearn this recommendation of diet. There are only 4 food groups that are to be avoided, and here they are. They're all high purine foods. As you know, purines are metabolized by the liver to produce uric acid. So alcohol, especially beer, of course, is the number one alcoholic form that precipitates gout. Binge drinking, of course, will do more to cause gout than anything else. Soft drinks, if they contain fructose, high fructose sugar, will increase formation of uric acid by the liver. Seafood, especially shellfish, you're talking about prawns, lobsters, crabs, and some forms of fish like sardines. They are very high in protein, in purines, and hence can precipitate gout. And then there are organ meats, liver, kidney, bheja, that is brain. So if you have these high purine foods, so do not tell vegetarians to stop any nutrients in vegetarian diet. And the only thing vegetarians need to do is stop soft drinks and alcohol. Non-vegetarians, of course, are not to be restricted from chicken, eggs. They can eat a lot of forms of fish, some forms of mutton. So please do not make their life unbearable than it already is. Question number 5. We come to now management of gout. Now, gout has two areas of management. One is managing the acute attack of gout, and the second is preventing recurrent attacks, preventing nephropathy, preventing kidney stones. So, a preventive treatment of gout. So, first of all, colchicine. We know that there are 3 drugs which are effective. Colchicine, Goutnil is the brand name. NSAIDs, most commonly used NSAIDs are, of course, indomethacin and naproxen, and steroids. These are the 3 formats of acute pain management in gout. When it comes to efficacy, all 3 are equally effective. For colchicine to be as effective as NSAIDs or steroids, we must start colchicine within 36 hours of onset of gout pain. That is not very difficult if the patient approaches you, and the patient will approach you definitely because the pain is excruciating. Gout is one of the most painful conditions that we have. So colchicine is effective. Let me tell you about the dose of colchicine. In the olden times, we used to give colchicine more frequently, till diarrhea occurs, etc. But now the dose of colchicine has come down, recommendation has come down. The textbook recommendation of colchicine dose, as soon as pain starts, give 2 tablets of 0.5 milligrams of Goutnil, stat, 1 more tablet after 1 hour, and then from the next day onwards, up to 3 tablets a day, or depending on the kind of relief that the patient has. Many rheumatologists tell us that you can go down with the dose even further. You can give 1 tablet stat and then maybe 1 tablet a day, or etc. So many people have different regimens of their own. The reason why colchicine dose, lower dose is preferred is because colchicine can cause significant GI disturbance, including diarrhea. So people have been trying to get the lowest dose possible. So The good thing about colchicine is that colchicine can be combined with steroids and it can be combined with NSAIDs. For example, NSAIDs cannot be combined with steroids. So if you want to give two drugs, maybe colchicine will be one of the two drugs. I'll come to colchicine's use as preventive or prophylactic or suppressive inflammatory drug later. So colchicine is a good drug for pain management, but it is not the first choice drug of most physicians. That brings us to the next question. Are NSAIDs the most common pharmacologic modality of treating acute gout? It is definitely the most preferred modality of treating gout. Yes. Now let's talk a little bit about NSAIDs. If a patient comes to you with gout, with severe pain, say of a small joint of the lower limb, what NSAID is the preferred NSAID? As most of you know, naproxen and indomethacin are used most commonly. But remember, if the patient has access to ibuprofen or diclofenac, all NSAIDs are almost equal. You have to be giving the correct dose. The mistake that we make in using NSAIDs is that we underdose the patient with NSAIDs. So remember, the correct dose of naproxen is 500 milligrams twice a day. The correct dose of ibuprofen is 600 milligrams 3 times a day in a 60 kg or more adult. If you use indomethacin, 25 to 50 milligrams 3 times is considered the dose. I would say give the first dose at least as 50 milligrams of indomethacin. Don't use sustained release preparation of indomethacin. You want acute onset effect. About NSAIDs, the problem is that many patients are older, many patients are hypertensive or have cardiovascular disease. Many patients have nephropathy, have diabetes, and NSAIDs therefore are not the ideal drug for people who are having comorbidities like these. So in these patients, you can use colchicine, but many people prefer steroids. So that brings us to the next question. Are steroids the preferred anti-inflammatory modality in the elderly with cardiovascular risk factors? And the answer is yes. Steroids should be used where NSAIDs have a relative contraindication. Patients has a GFR of 55. I will not use NSAIDs if steroids are available, and if the patient not a severe diabetic, uncontrolled diabetic. So steroids, there are two ways to use steroids. You all know that intra-articular steroids are the preferred method of administering steroids in monoarticular arthritis. We usually give solumedrol intra-articular. Some people give Kenacort, that is triamcinolone, intra-articular. So that is one method, and the other method is intramuscular. If the patient is severe pain, cannot take orally because sometimes gout causes nausea, then you can give intramuscular triamcinolone 40 milligrams also in an adult, or you give oral steroids in a dose of 1 mg per kg per day for a few days. Now that brings me to the duration of therapy. The duration of therapy is till the pain completely subsides with NSAIDs or colchicine or steroids or combinations of two drugs, and a few more days. So don't stop the medicines once the pain goes away. Continue the medicine a few days beyond the relief of pain, complete relief of pain. Now, if after the relief of pain, you are going to put the patient on urate lowering therapy, then there is a continuation of anti-inflammatory therapy, and we will come to that. That brings us to the question number 8. Should one avoid initiating urate lowering therapy during acute flares of gout? Now, this is the commonest mistake made by physicians. The answer to this, should one avoid initiating ULT? Yes. A patient comes to you with acute attack of gout. The patient's uric acid is at that time is say 7 milligrams per deciliter. Often the physician will start with NSAIDs and say allopurinol or febuxostat. This is disastrous, and I'll tell you why it is disastrous. First, let me tell you what is urate lowering therapy. Urate lowering therapy means treatment that inhibits the enzyme xanthine oxidase and therefore reduces the production of uric acid. This is the commonest form, reduction of formation of uric acid. The two commonest urate lowering therapy drugs therefore are allopurinol, brand name Uric, and febuxostat, many brand names. Now, urate lowering therapy, if you start during acute flares of gout, if you give it for the first time during acute flares of gout, the gout will worsen tremendously. The reason is any sharp fluctuation in serum uric acid, whether going down or going up. For example, seafood, shellfish will make the uric acid suddenly go up, alcohol suddenly go up, febuxostat suddenly go down. Any sudden change in uric acid worsens deposition of or supersaturation of uric acid crystals in the joint. Therefore, you can never initiate uric acid lowering therapy during the acute flares. Very, very important to understand this. Second, if the patient is already on allopurinol or febuxostat and gets an acute flare of gout, do not stop the febuxostat or allopurinol, because again, by stopping that, you will be causing a sudden rise in uric acid, which will worsen gout. So don't initiate therapy and don't stop ongoing urate lowering therapy during acute flares of gout. That is very, very important. That brings us to the next question. Which urate lowering therapy should you prefer? Allopurinol or febuxostat? The recommendation is very clear and very strong. Always use allopurinol over febuxostat. What is the reason? Allopurinol, as you know, causes more skin rash. Allopurinol is known to rarely cause the Stevens-Johnson syndrome. People are scared of the Stevens-Johnson syndrome, and hence many people have started preferring febuxostat. Also, febuxostat is pushed more by pharma companies simply because there is more profit in febuxostat, and therefore we have so many brands of febuxostat and maybe only a couple of brands of allopurinol. So, why should we use allopurinol? One, allopurinol is tested, time tested, much more. Second, febuxostat is very rapidly acting, so it lowers the uric acid much faster than allopurinol, and therefore it can worsen gout. And third, allopurinol has a better dose titration modality. You have 40 milligram febuxostat, 80 milligram febuxostat. Allopurinol, you start with 50 or 100 milligrams and go up to 800 milligrams. I'll talk about the doses soon. So, allopurinol must be the drug of choice if the patient has history of Stevens-Johnson syndrome, or if the patient with a lower dose of allopurinol starts developing a rash, you must switch to febuxostat. You have seen many nephrologists prefer febuxostat over allopurinol. Again, allopurinol remains the number one drug in CKD. The doses are lower in CKD, but you should prefer allopurinol according to me and according to evidence. Let us go to indications of urate lowering therapy. The most important, most common indication, of course, is 2 or more attacks of gout in 1 year. So, if a patient comes to you with the second attack within the same year, this patient you may consider for urate lowering therapy. If the patient says that both the attacks occurred because of binge drinking of alcohol, then you may ask him to improve his lifestyle and not start the urate lowering therapy. So, you can decide if the patient was on thiazides, you remove the thiazide and then wait for another attack of gout. So, you will take a call based on what actually caused the acute attack. If there is no apparent precipitant of the gout and if there are 2 or more attacks in a year, then you might consider this patient for urate lowering therapy. The second important indication is GFR less than 60. Any patient with low GFR should be put on urate lowering therapy if the uric acid is more than 6. The reason why they should receive this is because high uric acid worsens the kidney parenchyma and worsens kidney failure. I'm sorry. So this is very important. The third indication is if even one tophus is seen, say ear, joints, even one tophus as you know is a deposition of uric acid crystals, which is sometimes even visible to the naked eye and sometimes radiologically. One tophus is enough to tell you that joint destruction has started and you must start urate lowering therapy. Absolute uric acid value more than 9 milligrams. This is an area of some controversy, but if the patient is asymptomatic, no gout ever, no precipitant of uric acid like low dose aspirin or thiazide, etc., and no kidney stones ever, and the uric acid is more than 9, this patient deserves urate lowering therapy. And then uric acid, kidney stones, even one episode of urolithiasis due to uric acid stones becomes a good indication for urate lowering therapy. When you start urate lowering therapy, your treatment target is 6 milligrams. Allopurinol, you will start with 100 milligrams per day in non-CKD patients and 50 milligrams per day in CKD patients and gradually increase every 3 to 4 days, looking for rash. If rash appears, stop it and switch to febuxostat. So, the maximum dose of allopurinol is 800 milligrams. The maximum dose of febuxostat currently is 80 milligrams. So, you can choose either of the two, prefer allopurinol. How long should you give urate lowering therapy? Urate lowering therapy will be usually lifelong because the disease is lifelong. When you start urate lowering therapy in a patient who has just come to you with the second or third episode of gout, you are not going to start immediately during the acute attack of pain. When do you exactly start urate lowering therapy? Patient has had 3 episodes of gout, you want to start urate lowering therapy, you must wait for 2 to 3 weeks after the attack has completely subsided. Then you should start the therapy, and when you start the therapy, remember, you have to give anti-inflammatory drug for 6 months at least along with the urate lowering therapy, meaning you will give colchicine in a small dose of 0.5 milligram once a day or maybe even half a tablet once a day for 6 months along with the allopurinol or febuxostat. This is very important because in the first 6 to 24 months, urate lowering therapy will cause an increased incidence of acute attacks of gout. So that is about urate lowering therapy. And last question, this I already addressed. Does the frequency of gout attack increase in the first 6 to 24 months of starting ULT? It does, and this is surprising. Why should urate lowering therapy cause more episodes of gout? And that is because of the fluctuation in the uric acid levels due to the therapy. And often patients will get, if they used to get 2 attacks per year, they might get 3 or more attacks in the first 1 year or so of the urate lowering therapy. So it is important that at least 6 months you give colchicine, and if the patient does not get any episode in those 6 months of colchicine, maybe you will stop colchicine and see. So these are the 10 questions which we try to answer, and now some more take-home messages for you. One, and these are some personal interpretations of the data. If a patient of hypertension comes to you and his baseline uric acid is more than 6, then try to avoid thiazides in such a person, because you know that the thiazides will increase this baseline uric acid more than 6. Of course, the patient will not immediately get gout, but the patient will become prone to gout in future, will become prone to kidney problems in future, will become prone to urolithiasis in future. So thiazides as antihypertensives I would diligently avoid in hyperuricemia. Avoid the classic cascade prescription where urate lowering therapy is added when hydrochlorothiazide causes hyperuricemia. Most of us know that thiazides, both HCTZ and chlorthalidone, are commonly used as antihypertensives. Often these patients, when they get their health checkup done, will have a uric acid of 7, 7.5, etc. Now, it is very common to add febuxostat or allopurinol because of this report. Remember that removing hydrochlorothiazide is important. You don't give a medicine for tackling the side effect of a previous medicine. That is called a cascade prescription. You don't want to do that. You give hydrochlorothiazide, causes hyperuricemia. You give allopurinol, causes a rash. You give something for the rash, etc., etc. Should not happen. So, this is something that you often find while correcting prescriptions already being meted out to the patient, and take care of removing the hydrochlorothiazide so that you don't unnecessarily give your urate lowering therapy. Weight loss is an important method of reducing frequency of gout attacks, and this is something that we often talk about, sometimes implement, sometimes we don't. We know that hypertension, diabetes, gout, sleep apnea are all related disorders. Metabolic diseases are related. Gout is a metabolic disease as well as an inflammatory disease, both. Weight loss reduces the frequency of gout attacks. The patient may avoid urate lowering therapy by reducing weight significantly. 3 drugs that decrease serum uric acid levels, 3 important non-gout related drugs are vitamin C, losartan and fenofibrate. Interesting is losartan. If the patient is hypertensive, has a uric acid which is say 6, 7, don't start the patient on urate lowering therapy simply because you need a minimum level of 9 in an asymptomatic patient to start urate lowering therapy. Such a patient you may want to give losartan. That might be an interesting choice of drug. It is a uricosuric agent. Fenofibrate incidentally reduces serum uric acid and so does vitamin C. Low dose aspirin, we all know that increases serum uric acid. High dose aspirin reduces serum uric acid, slightly paradoxical effect of aspirin. But most patients take low dose aspirin if they take aspirin at all. So, many of our cardiac patients are on low dose aspirin and they are also on chlorthalidone or hydrochlorothiazide or loop diuretics. These patients already have 2 drugs that cause hyperuricemia. So, you must take care of these patients and check if they get some joint pains, get the uric acid tested. If a low dose aspirin patient has a higher uric acid then and has already got gout, then you may want to switch from aspirin to another antiplatelet like clopidogrel. This is something that you can think of if the gout is not under control. Another drug that causes hyperuricemia is pyrazinamide. We all know that pyrazinamide invariably causes, not just causes, it's not a side effect, it's a sequelae of pyrazinamide. It invariably causes high uric acid levels. And pyrazinamide, when it causes hyperuricemia and the TB patient gets joint pains, it is useless to treat that hyperuricemia with colchicine, does not work. In fact, it might be counterproductive because of drug interactions. It is useless to give allopurinol or febuxostat to this drug. You just have to ride the hyperuricemia out. If the hyperuricemia is causing significant problems, you may have to withdraw pyrazinamide, but you just hope that the 2 months of pyrazinamide, if it's a standard drug sensitive TB, then 2 months of pyrazinamide are you tied over that 2 months with accepting hyperuricemia as a problem. A useful, if difficult to follow first aid in acute gout, as we all know, is ice application. Why is it difficult to follow? You must remember the first description of gout when it was first described by a doctor. Even if the bed sheet touches the patient's foot in podagra, for example, the patient shouts in pain. How can the patient tolerate a cold ice application to that inflamed joint? So, it is not easy to touch the patient at that time, let alone massage the patient with ice. So, difficult to follow, but this is the first thing that you can tell the patient to try. Another important thing is we often blame proteins for aggravation of gout. Dairy products, proteins from dairy actually have a protective effect in gout. So does coffee have a protective effect in gout, just like estrogen has a protective effect in premenopausal females. Well, that's about it. I must have missed a few points. I'm sure you will ask me questions which will make me remember those points. Thank you so much. Dr.
Yes,
Fatima.
sir. Thank you so much. It was wonderful as always. The reactions are just continually pouring in. Thank you, doctors. We have a ton of queries. Yes, we'll just. So the most obvious one, sir, is the. Could you just reiterate the therapeutic protocol for hyperuricemia? So
Uh, yeah,
is
so
hyperuricemia
hyperuricemia,
as well.
yeah, therapy for hyperuricemia. First of all, hyperuricemia, you have to remove precipitants. For example, remove alcohol, remove organ meats, etc. Then remove the drugs that cause hyperuricemia, for example, diuretics. Then uh, ask them to follow a lifestyle which includes weight loss. Now, if hyperuricemia is not causing gout, it is not causing urolithiasis, do not treat hyperuricemia unless the uric acid is 9 milligrams per cent or more. Asymptomatic patients, like if you will see a report of 8.5 uric acid and you will be tempted to start, mistake, never start. So if you have had episodes of symptoms, like you have had even one episode of uric acid stones or two episodes within 1 year of acute gouty arthritis, then this patient may be considered, it's not mandatory, it may be considered to receive. So we have indications of taking medicines that you can always go through again. Yeah.
Yes. Just get the bottom one. Dose titration of allopurinol.
So we again discuss that, but I'll tell you again.
Yes, sir.
If the
Most of the
patient's,
questions.
if the GFR of the patient is low, below 60, then you must start with 50 milligrams of allopurinol and gradually build up the dose till you achieve a uric acid. In CKD, you have to get below 6 milligrams per cent, sometimes below 5 milligrams per cent in CKD. So you must achieve that target and stop at that dose which achieves the target. Uh, Febuxostat dose titration is simple. You start with 40 and may go up to 80 milligrams per day.
Yes, sir. So use of long-term spironolactone, is it a risk factor for gout at a later stage?
So amongst diuretics, spironolactone I don't think causes uric acid elevation. It's thiazides, non-thiazides, and like indapamide, for example, and metolazone also, and loop diuretics like torsemide or Lasix, furosemide. These all cause high uric acid. I don't think spironolactone is used for treatment of this. I'm not sure. If you know something, do let me know.
Yes. Sir, can a chronic gout present with burning feet syndrome?
No, chronic gout can present with periarticular disease. Yes, it can present with enthesopathies. It can present with carpal tunnel syndrome, but I don't think it can present with burning feet syndrome.
Okay. So we do have, I'll club these two, management of gout in the chronic stages, as well as what home remedies can we recommend to the patients?
Uh, I don't know about home remedies if there is any related to gout. Of course, we know the restrictions at home, which is alcohol, etc. But I don't know any home remedies. What is the second part you said?
Going back to that, sir, management of gout in the chronic stages.
So chronic gout again is difficult. You have to keep on giving urate lowering therapies. Many patients with chronic gout develop a syndrome very similar to rheumatoid arthritis. But you must remember that the diagnosis, correct diagnosis, has to be made because DMARDs like methotrexate, etc., do not work in gout. Neither do biologics. So you will have to treat with urate lowering agents continuously and treat the acute flares with anti-inflammatory drugs as we usually do. This I have not spoken about the diagnostic tests in gout. We all know that serum uric acid is not reliable during acute attacks. The diagnostic test is, of course, aspiration of the joint fluid and looking for the typical crystals in a polarizing microscope. So this test is rarely done because we usually give a clinical diagnosis. But sometimes because we don't do this test, we will miss pseudo gout or other forms of arthritis like palindromic rheumatism. So I think we must try to treat gout, diagnose gout and do the differential diagnosis correct. Yeah.
Yes. Dr. Ravindra has asked, in diabetic gout, is it justified? Is loading steroids justified?
As I said before also, if a patient is diabetic and say has CKD, then you can't give NSAIDs during acute attacks. If the patient is diabetic and has intolerance to colchicine, because colchicine has been taken before and the patient develops diarrhea, your only choice now remains steroids. So yes, I would give steroids to a patient. If the patient is not well controlled, then I would give an intra-articular steroid, which may have a lesser systemic problem. Otherwise, systemic steroids with maybe more aggressive control of diabetes will be indicated. So you can give. There is no absolute contraindication.
Yes. So I'm only taking this because I see a couple of questions still coming in related to it. Regarding asymptomatic hyperuricemia, what should be done? How should we go about that?
Asymptomatic hyperuricemia, meaning is hyperuricemia which does not cause joint pains, which does not cause kidney stones. This is called asymptomatic. Asymptomatic hyperuricemia in a patient who does not have CKD should be treated only if the uric acid levels is more than 9. If the patient has CKD stage 3, that is less than 60 GFR, then asymptomatic hyperuricemia should be treated if the uric acid is more than 6. So you must be more aggressive in CKD.
Yes, sir. Also, in that same context, do these patients need dietary changes for lifetime?
As I said, dietary changes are not very important because many patients are forced to give up a lot of things. Especially vegetarian proteins should not be given up at all. But yes, I would say if you have infrequent episodes, like first episode occurred 1 year back, second episode now, then in between episodes, I would not be very strict about withholding many things. Some patients will have a social drink or so. I would not mind that. So you can allow some uh, some excursions in diet and drinks. But otherwise, I would say, yeah, if a patient has now very frequent episodes, which starts after a few years, then this patient has to go off alcohol completely, off shellfish completely.
I hope that clears the questions regarding this, doctors. Dr. Sheila has asked, so does febuxostat still have the black box warning or has it been removed?
Uh, I don't know whether it has been removed, but I do know that it was there and I still think it might be there. Dr. Sheila might also know if she has any update on that. The black box warning that Dr. Sheila is talking about is the warning that febuxostat is associated with an increased incidence of myocardial infarction, and therefore there was a warning given by US FDA. The company did come up with more reports and more studies which showed that that is not the case. I don't know whether US FDA has removed the warning, but it probably has not. But I'll have to be sure. Either way, if there is some signal that febuxostat increases incidence of acute MI, I would be very wary of giving it in the elderly who have atherosclerotic disease.
Dr. Poonam asks, dosage of oral steroids in acute phase and duration.
So the dosage of oral steroid is 1 mg per kg per day. The duration is till the complete disappearance of inflammation in the form of pain and swelling, and a few days beyond that. How many days beyond that is very subjective, but at least a few days beyond the complete resolution of inflammation. Yeah.
Got it. Dr. Deepak Singh has asked, so if you could reiterate on pseudo gout and what is the possible management?
Yeah, this is an interesting area which I did not cover at all. Pseudo gout is a disease, of course, as you know, is a disease of deposition of calcium pyrophosphate, and this CPPD, they call it calcium pyrophosphate deposition disease, uh, uh, popularly known as pseudo gout, is a disease more of the elderly. It is not a disease of the younger or middle-aged people. Pseudo gout is more polyarticular, but it can start monoarticular, but more polyarticular than acute gout, than regular gout. And the diagnosis is again by demonstrating the crystals under a polarizing microscope. Luckily, the acute treatment is with colchicine, which also has effect on gout, or with NSAIDs. However, febuxostat or allopurinol do not have any role to play in pseudo gout. Pseudo gout is, I've never diagnosed pseudo gout, but I'm sure I've missed many pseudo gout patients. Pseudo gout will typically present with arthritis, which is asymmetric, sometimes polyarticular, and you will mistake it as osteoarthritis because it happens in the elderly. And these patients, if you see inflammatory flares with over a baseline chronic arthritis, then you might think of pseudo gout. And these patients, therefore, will not respond to DMARDs or will not respond to febuxostat or allopurinol.
Yes. Role of sodium bicarbonate in gout, Dr. Sunil Patil.
I don't know of any role of sodium bicarbonate. The only role that I know of soda bicarb in this context is maybe in CKD, but in gout, I'm not sure if you're trying to refer to something. But no,
Okay.
not to my knowledge.
Okay, sir. Dr. Sunil Narang, so role of gold in gout treatment.
I don't know the role of gold. I used to know about the role of gold salts in rheumatoid arthritis in the 1970s and 80s maybe, but the role of gold now in rheumatoid arthritis is also absent. So yeah, no role.
Okay, sir. Dr. Goswami says, very nice and beautiful talk. Dr. Simran has asked, is gout permanently curable?
Secondary gout is permanently curable, meaning gout due to say hydrochlorothiazide is permanently curable, but by removing the precipitant. But otherwise, gout is a heritable disorder. About 60% of patients have family history of gout, and therefore it has a genetic basis. The genetic basis is not complete, meaning if you have twins, monozygotic twins, not both will get gout all the time. 50% of the concordance might be there. But no, it is not a curable disease. It is a chronic disorder.
Yes. What should be done in congestive heart failure patients with hyperuricemia, where diuretics is the cornerstone of therapy?
This is a good question, and this is a problem that many patients face and probably deal with incorrectly. A patient, I'll just go straight to the patient. The patient is 65 years old, has a baseline uric acid of 6, has a normal creatinine, and the patient is given diuretics like furosemide, for example, because for heart failure with reduced ejection fraction, and this patient's uric acid jumps to 7.5. What do? You have to continue the diuretic. So what do? Don't give febuxostat. Don't give urate lowering therapy unless the patient has symptoms or CKD. So calculate the GFR. If GFR is above 60, do not give urate lowering therapy, even if the uric acid is going up on the diuretic. Yeah.
Got it. Dr. Kamal has asked, are rheumatoid arthritis and osteoarthritis synonyms for gout? Is this correct or not?
No, they're three distinct disorders. They are not synonymous at all, with completely different pictures and management.
Dr. Binod, asymptomatic hyperuricemia in CKD needs treatment with uricosuric agent or not? I think we covered it.
You said uric agent.
Uric agent, yes.
Uricosuric agent like probenecid, I suppose you are talking about. The first choice still remains if you want to treat CKD and hyperuricemia, even if the hyperuricemia is asymptomatic. In CKD, you have treated about 6 milligrams per deciliter. You still first treat with allopurinol or febuxostat, not with probenecid. You give urate lowering therapy. What is urate lowering therapy? That decrease the formation of uric acid by inhibiting xanthine oxidase. Uricosuric drugs like probenecid basically cause uricosuria and therefore cause reduced serum uric acid. You don't give uricosuric drugs as first choice in any gout, almost any gout.
Got it. Dr. Jaimin Patel, how frequently to keep checking uric acid levels in chronic gout treatment?
So as we know, the target is 6 milligrams per deciliter. If you have achieved that target on say an X dose of allopurinol, then you don't need to repeat very frequently. Maybe 6 months or 1 year would be enough. If the target is not achieved, then maybe you titrate the dose, and after each titration, maybe a month, you will repeat the blood test for uric acid.
So, how long do we have to treat in acute flares of gout?
Again, a very good question and very variable answers you will get from different people. As we said, you give NSAID, steroids or colchicine for the duration of inflammation and continue it for several more days after the inflammatory flare has subsided. So how long? I can't say 10 days, 15 days, 20 days. It can be several days, a few weeks. And if you are going to give urate lowering therapy after the acute flare has subsided and 2 weeks have passed, then you may have to give colchicine for 6 months at least.
Okay, so combining two questions here. So, treatment of chronic gout with allopurinol or febuxostat, can we give intermittent therapy or treatment has to be continued even if symptoms cease to exist?
If you have decided to treat gout with urate lowering therapy for the indication that we have already mentioned, you cannot interrupt therapy. Interruption of therapy will only mean that you will cause fluctuations in serum uric acid levels, and therefore we will precipitate or cause more joint damage than giving long-term therapy. So once you have decided to treat with ULT, you keep treating without interruption.
Okay, sir. Okay. Does topiroxostat, is that better than febuxostat?
I don't know this new molecule. In fact, I don't even know if it is there in India. Dr. Neera, I'm so sorry, but no information.
Yes, Dr. Rahat has asked, patients with chronic lymphocytic leukemia is what I'm guessing, has hyperuricemia, how should they be treated?
Again, I don't know whether the patient is symptomatic or not, but I presume that the patient is asymptomatic with hyperuricemia, CLL, or for that matter, any malignancy may have an hyperuricemia, especially if they are receiving some therapy. I would say still wait for the 9 milligram per deciliter level in asymptomatic patients with normal kidney function before you start higher therapy. Yeah.
Okay, so Dr. Sanjeev has asked a case-based question. So the patient, middle-aged man, non-diabetic, no hypertension, preferred drug for gouty arthritis in rheumatic heart disease.
I presume you're saying patient with acute gout, not just chronic prophylactic treatment, but acute gouty arthritis, whether you will choose steroids or NSAIDs or this. Patient has rheumatic heart disease, moderate mild stenosis, he is written, hypertensive. Since the patient has comorbidities, including a cardiac disease, I would prefer colchicine and or steroids. I would not mind giving steroids to this patient.
Okay. Dr. Deepak Singh, when can we give pegloticase and what should be the dosage in gout?
I have no experience with pegloticase. As you know, pegloticase is an enzyme which converts uric acid to allantoin, which is an inert water soluble molecule, and it works in a manner different from allopurinol and febuxostat. So yeah, it's a drug that I have never used and I don't know much about in terms of dosages.
Yes. Dr. Lakshmi has asked, neurological effects due to gout, are they any?
Dr. Lakshmi, I can't think of any neurological effects of any central neurological effects of gout. Neither can I think of any peripheral nervous system disorders due to gout. No.
Got it. We have Dr. N.K. Kumar dropping in the dosage of topiroxostat and also saying it's better than febuxostat in CKD.
In CKD, okay. So thank you, Dr. Kumar. Yes.
Yes.
And it is available in India, more important.
Yes. I think we've covered all the questions. I kept one for the last one where one of the doctors was saying, I learned all about gout in such a short time and that was really nice. So thank you. Thank you, doctors, for your wonderful questions. I think we missed this one. We'll take this one. So would that be okay? Asymptomatic patient with uric acid level above 9, do we start coxsackie or along with allopurinol or allopurinol alone?
No, if the patient has not had an acute flare of gout, as the patient is asymptomatic, as you said, you start allopurinol alone. Don't give colchicine.
intra-articular glucocorticoid can be given along with indomethacin.
So the combination of steroids and NSAIDs I don't like personally if they're both oral, but if you have to give both, for what reason I don't know, but if you have to give both, then yeah, intra-articular might have lesser GI side effects when given with indomethacin. But I would be wary of giving both. Both are beautiful drugs. I don't see the need to give two of these together.
Last one, recurrent swelling of feet with increased uric acid. Should febuxostat be given lifelong?
Yeah, it's a
Popular
broad question. Should recurrent swelling of feet. Now, recurrent swelling of feet, when you say it means you're talking about bilateral, I don't think this recurrent swelling will be due to uric acid, one. And you're saying swelling, you're not saying arthritis of the feet, which again makes me wonder if you are not talking about gout at all or not. So, yeah, I think you might have to go through the talk again. Maybe you might get your answer in the talk.
Yes, with that, we can wrap up with Dr. Mansoori's comments saying very informative session, and thank you, sir. On behalf of all the attendees and Team Medflix, sir, thank you once again. Looking forward to seeing you.
Thank you so much. Bye-bye.